So, what is osteoporosis? I'll give the NIH definition. They define it as a skeletal disorder characterized by compromised bone strength, predisposing a person to an increased risk of fracture. Basically, the bones have become weak and brittle, and that happens when we lose too much bone or we don't make enough bone or both. I've listed the major risk factors for osteoporosis. Age. So, as we age, our bone density will tend to decline and our bone remodeling processes become less efficient. Hormone decline. In menopause, women will have declines in estrogen, progesterone, and testosterone, and men can see decline in their testosterone levels. Nutritional deficiencies like calcium and vitamin D and other nutrients, physical inactivity and lack of weight bearing, having a family history of osteopenia or osteoporosis, smoking, and excessive alcohol intake will both reduce bone density. And then I've listed other medical conditions, and here that would include things like rheumatoid arthritis and other autoimmune diseases, many of the gut disorders, so Crohn's disease, ulcerative colitis. These conditions will cause bone loss because of chronic inflammation and malabsorption. Also, celiac disease, as well as non celiac gluten sensitivity because of impairment of nutrient absorption. Irritable bowel syndrome is associated with an increased risk of osteoporotic fractures, and that's due to intestinal inflammation. GERD or acid reflux disease, especially if someone is using acid blocking medications, will increase the risk of osteoporosis. Liver diseases, and also anyone who's had a history of gastrointestinal surgeries or a resection of part of their intestinal tract. And then some hormonal disorders that will lead to osteoporosis, hyperthyroidism and hyperparathyroidism. And then I've also listed here certain medications, so steroid medications, some anti-seizure medications, some antidepressant medications, acid blocking medications, and even some cancer treatments can lead to bone loss. And what are some of the things that we can do to prevent osteopenia and osteoporosis? So, a bone healthy diet with adequate protein and the right nutrients, supplements, physical activity and exercise, controlling glucose and blood sugar, and reversing insulin resistance, reducing inflammation. So, inflammation anywhere in the body is a well known cause of bone loss. So, inflammation in our skin, in our joints, in our intestinal tract, in our mouth, really inflammation anywhere in the body can contribute. We also want to optimize gut health. And we want to avoid and remove our exposure to toxins. I'm just going to get sidetracked here for a second here and show you this article from 2021, the journal Integrative Medicine. Environmental toxins are a major cause of bone loss. So this shows cadmium, lead, mercury, chemicals such as pesticides, phthalates, bisphenols, or BPA disrupt bone metabolism in many ways. Body levels of these toxins directly correlate in a dose dependent manner with risk of fracture and osteoporosis. So, toxins. Another article, 2023, International Journal of Molecular Sciences. Endocrine disruptors, endocrine disruptor induced bone damage due to hormone dysregulation. This study highlights the harmful effects of environmental toxicants on bone formation. So, talking about chemicals from pesticides, plastics, our personal care products, household products, many of these environmental toxins will contribute to bone loss. And then, where we don't smoke, avoid excessive alcohol, don't drink soda. There are ingredients in soda that will cause bone loss. And then we also want to reduce our stress and get plenty of sleep because excessive stress and inadequate sleep are big contributors of inflammation, and inflammation will lead to bone loss. This article from 2019 in the journal Menopause, the association between soft drink consumption and osteoporotic fractures among postmenopausal women, shows consuming more than 2 servings of soft drinks per day on average showed potential associations with higher risk of hip fracture among postmenopausal women. And then bioidentical hormone therapy as another approach for prevention of osteopenia and osteoporosis. So, what are bioidentical hormones? Bioidentical hormones are natural plant-based hormones that are used for hormone replacement therapy, for hormonal imbalances, perimenopause, menopause, and testosterone deficiency. These hormones are created to be identical to our own hormones, and they are biochemically indistinguishable from human estrogen, progesterone, and testosterone. So they exactly mimic our own hormones. These hormones can be used to ease symptoms related to hormone imbalances and deficiencies, including osteopenia and osteoporosis. How are bioidentical hormones different from traditional hormone therapy? Well, traditional hormones are synthetic hormones. They're not identical to our own hormones. They tend to cause more unwanted side effects because they're not the same as our hormones. And for example, synthetic estrogen is actually horse estrogen. It goes by the brand name Premarin, which comes from pregnant mare's urine, Premarin. It also goes by the name conjugated equine estrogen, or CEE. Synthetic progesterones aren't even progesterones at all. They're actually called progestins, and they go by the brand name Provera or medroxyprogesterone acetate, or MPA. And these progestins are chemicals synthesized to mimic progesterone, but they're not progesterone. And so, for that reason, they also tend to cause unwanted side effects. BHRT is completely customizable so that you get what you need, no more or no less. And it's not like synthetic hormones where there's only a few doses to choose from, where every woman has to choose from one or two different doses. And that would be like saying every woman has to wear either a size 6 or a size 11 shoe, and that just doesn't work. But with BHRT, it can be completely customized to any dose that a woman needs. The other benefit is that they're easily monitored in the blood. We can measure blood levels of these hormones because they're natural. You can't monitor synthetic hormones in the blood because they're chemicals that don't belong in our blood, so there's no blood test for them. BHRT is also transdermal, so they're applied topically in the form of a cream, typically. Oral estrogens increase side effects. So Premarin, which is the traditional synthetic estrogen, is taken orally, and then BHRT can't be patented because they come from natural substances. The pharmaceutical companies can't patent them, and so they're not promoting them because there's no money to be made in them. So I just wanted to show the differences. So Premarin is the synthetic horse estrogen. Estradiol is human estrogen. Progesterone is the human progesterone, and then medroxyprogesterone acetate or Provera is the synthetic progesterone, and then a molecule of human testosterone, and then testosterone cypionate is synthetic testosterone. So you can clearly see there are differences between the synthetic versions and the human versions. And if you're going to take hormone therapy, you're going to want to take something that's identical to our own natural hormones. So women might consider bioidentical hormone therapy if they're having irregular periods, hot flashes, night sweats, sleep disturbances, mood swings, fatigue, midsection weight gain, decreased libido or orgasm, vaginal dryness, brain fog, joint stiffness, and osteopenia. Men might consider testosterone therapy if they're having fatigue or low motivation, depression, decreased libido, erectile dysfunction, muscle loss, memory loss, or bone loss. And men and women don't have to have any of these symptoms to consider hormone therapy, because hormone therapy really slows the aging process. It just makes you feel better, and they can be used to prevent osteopenia and osteoporosis. So why isn't everyone taking bioidentical hormone therapy? Well, in the 1960s, 70s, 80s, and 90s, everyone was, and that includes synthetic as well as bioidentical. All women were being prescribed hormone therapy when they entered perimenopause and menopause. Primary care doctors, OBGYNs were always prescribing these patients from the 1960s to the 1990s. All women were put on this kind of therapy, and not being prescribed this type of therapy or hormones would be considered bad medicine at that time. But all of that changed overnight in July of 2002. And that's when the results of the Women's Health Initiative study came out. And that was a study that started in 1996, and it was stopped abruptly before it was completed, only after 6 years, because they were finding in that study that women put on hormone replacement therapy were getting a higher risk of breast cancer, heart attacks, and strokes. And so overnight, all doctors, primary care doctors, OB/GYNs stopped prescribing hormone therapy to anybody, and all women stopped taking their hormones because everyone was afraid and confused. Everyone was terrified. And it got enormous media coverage by the news. And the truth is that since then, so many articles, so much literature has come out showing that the results of that study were false, that the study was so poorly done. Um, the problem is that the news is not reporting that hormones are safe and good for you because it doesn't bring shock and awe. It doesn't bring fear. It doesn't make big news. And so the news isn't reporting it. And the other problem, too, is that many doctors aren't staying up to date on the latest research on hormones. And so everyone is still afraid of the hormones. But what I want to show you is that since then, since that 2002 study showing those results, many articles have come out. Many research studies have come out showing that the results were false and that study was very poorly done. This article from 2017 from the Journal of the American Medical Association, JAMA, actually took the exact same women from that Women's Health Initiative study, the same participants from that initial study, and followed them for 18 years. So after the study was stopped, they continued to track them for another 18 years. And what they found among the 27,347 in that original study, that hormone therapy with conjugated equine estrogen and medroxyprogesterone acetate for a median of 5.6 years, or conjugated equine estrogen alone for a median of 7.2 years, was not associated with risk of all-cause cardiovascular or cancer mortality during the cumulative follow-up of 18 years. So they continued to follow those women after that study was stopped and found that women were not dying earlier. They weren't having more cancer or cardiovascular disease than the women that were on the placebo in that study. In fact, they actually found that the quality of life, prevention of osteoporosis, prevention of heart disease, Alzheimer's disease, increasing sexual satisfaction, eliminating hot flashes and night sweats in the women who were on hormones compared to the women that were on placebo. The women on hormones actually did better. They also found in that study that hormone replacement therapy reduced hip and vertebral fracture risk by 34% and osteoporotic fractures by 24%. And the major flaws of that Women's Health Initiative study, one problem with it was that they only allowed older women to participate in the study. So all of the women in the study were at least 10 years past their menopause. And the reason that they did that, the reason that they didn't choose newly menopausal women for the study was because the only way that they could keep the women from knowing if they were on the hormones or the placebo was that none of the women could be experiencing any hot flashes or night sweats. Because if they got the hormones, their hot flashes and night sweats would go away. If they got the placebo, they wouldn't go away. So they couldn't involve any women in the study that were in the early stages of menopause. They could only include women that were at least 10 years past their menopause. And so these were older women. They were sicker. They already had heart disease or strokes. They weren't in good health. And the other problem with the study was that they didn't include bioidentical hormones in the study. They only included Premarin and Provera, or conjugated equine estrogen and medroxyprogesterone acetate. And bioidentical hormones behave completely differently than the synthetic hormones, and they have a decades long track record of safety. But when they found that Premarin and Provera were causing problems, they labeled all hormones as bad. And so all types of hormones were stopped in 2002, unfortunately, even though only these two were the ones included in the study. And then here's another study from 2014 in the journal Steroid Biochemistry and Molecular Biology, the Women's Health Initiative trial and related studies 10 years later. It revealed that starting hormone therapy in postmenopausal women less than 10 years from their last menstrual period appears to have less risk. And, this is, before 2002, doctors prescribed hormones to women that were newly menopausal. They were just entering the transition. They didn't wait 10 years later when they've already been, they've already suffered with all of their symptoms. They initiated hormones early. Data supporting the use of hormone therapy administered to postmenopausal women showing it to have more benefit than risk for symptom control, prevention of bone mineral loss and fracture, and improvement of the metabolic profile in women who began hormone therapy when they were less than 60 years of age and had their last menstrual period less than 10 years previous. Confirmation that hormone therapy for most newly menopausal women is safe and effective. Another study from 2005, fertility, sterility. The therapeutic regimens resulted in prevention of atherosclerosis and reductions in coronary artery disease mortality. It is our conclusion that the Women's Health Initiative hormonal replacement study had major design flaws that led to adverse conclusions about the positive effects of hormone therapy when initiated appropriately in a population of younger, more recently menopausal women, has promised to yield a more favorable risk-benefit outcome. From 2006, nuclear receptor signaling. In contrast to the conclusions reached by the Women's Health Initiative and the National Heart, Lung, Blood Institute, I conclude that treatment of postmenopausal women with estrogen and progesterone, or Prempro, does not increase the risk of cardiovascular disease, invasive breast cancer, stroke, or venous thromboembolism. From 2003, the journal Climacteric Hormone Replacement Therapy in the Post-Women's Health Initiative Era. The target population used in the Women's Health Initiative is not representative of the target population for whom menopausal hormone therapy is normally considered. Since their publication, the relevance of the Women's Health Initiative study results for everyday clinical practice has been the subject of controversy. The Women's Health Initiative targeted a group of women who were much older than those normally treated and who had numerous other risk factors. These were not women for whom a practicing clinician would think about initiating hormone therapy with the regimen that was used. 0.625 milligrams of conjugated equine estrogens plus 2.5 milligrams of medroxyprogesterone acetate, those are high doses, would not seem appropriate for any indication. Focusing on data taken out of context and without reference to subject profiles, the media created an emotive wave of uncertainty for patients and physicians. It's clear that hormone therapy is effective for postmenopausal symptoms and osteoporosis prevention. And then this is a very recent study. This just came out in December 2023 in the journal Menopause. Get this out of the way. More recently, the Women's Health Initiative publications acknowledge hormone therapy as the most effective treatment for managing menopausal vasomotor symptoms, and that conjugated equine estrogen alone reduces the risk of breast cancer by 23%, while reducing breast cancer death by 40%. And then here I didn't highlight this, but the sole remaining concern is a small increase in breast cancer incidence with conjugated equine estrogen and medroxyprogesterone acetate together. But remember, these aren't the bioidentical, these aren't the natural hormones, these are the synthetic hormones. But a small increase, 1 per 1,000 women, but no increased risk of breast cancer mortality. Let's see, and women's health findings have reduced the incidence of breast cancer in the United States. A generation of women has been deprived of hormone therapy largely as a result of this widely publicized misinterpretation of the data. So one study that Women's Health Initiative 2002 results, one study showing those poor outcomes, but multiple studies reversing the findings of that one study. And then what is the evidence? I wanted to share the evidence that hormone therapy is beneficial for bone health. So 2022 in the journal Climacteric, hormone therapy for postmenopausal osteoporosis management. This study reviewed evidence from randomized controlled trials, systematic reviews, and meta-analysis, and summarized high-quality evidence on the efficacy and safety of menopausal hormone therapy in management of postmenopausal osteoporosis. 2021, Best Practice Research Clinical Endocrinology and Metabolism, menopausal hormone therapy for the management of osteoporosis. Let's see this here. Estrogen deficiency leads to rapid bone loss, which is maximal within the first 2 to 3 years after the menopause transition and can be prevented by menopause hormone therapy. Not only menopause hormone therapy prevents bone loss and the degradation of the bone microarchitecture, but it significantly reduces the risk of fracture at all bone sites by 20 to 40%. It's the only anti-osteoporotic therapy that has a proven efficacy regardless of basal level of risk, even in low-risk women for fracture. Over the last years, subsequent reanalysis of the Women's Health Initiative and further trials have challenged the initial conclusions of the Women's Health Initiative. It's now clear that the individual benefit-risk balance of menopausal hormone therapy is dependent on the individual risk profile in each woman, as well as whether estrogen is opposed or unopposed, the type of estrogens and progestogens, or doses and routes of administration. In the absence of contraindication, use of menopausal hormone therapy should be considered as a first option for the maintenance of bone health in those women where specific bone active medications are not warranted. 2018, Osteoporosis International, Estrogen Therapy for Osteoporosis in the Modern Era. Menopause predisposes women to osteoporosis due to declining estrogen levels. This results in a decrease in bone mineral density and an increase in fractures. The Women's Health Initiative randomized controlled trial first proved hormonal therapy reduces the incidence of all osteoporosis-related fractures in postmenopausal women. However, the study concluded that the adverse effects outweighed the potential benefits, leading to a significant decrease in hormone therapy used for postmenopausal women or symptoms. Subsequent studies have challenged these initial conclusions and have shown significant efficacy of hormone therapy in various doses, durations, regimens, and routes of administration. These studies support that hormone therapy improves bone mineral density and reduces fracture risk in women with and without osteoporosis. The studies suggest that low dose and transdermal hormone therapy are less likely associated with the adverse effects of breast cancer, endometrial hyperplasia, coronary artery disease, and venous thromboembolism or blood clot, previously observed in standard dose oral hormone therapy regimen. So they're saying here that transdermal or topical is safer than oral hormones. We propose that hormone therapy should be considered for the primary prevention and treatment of osteoporosis in appropriate candidates. Hormone therapy should be individualized, and the once lowest dose for shortest period of time concept should no longer be used. 2014 Journal Steroid Biochemistry and Molecular Biology, Prevention and Treatment of Postmenopausal Osteoporosis. In the beginning, that is from the 1960s, when a link between menopause and osteoporosis was first identified, estrogen treatment was the standard for preventing bone loss. This continued until the Women's Health Initiative study in 2001 that published data on 6 years of treatment with hormone therapy that showed an increase in heart attacks and breast cancer. In later analyses, the Women's Health Initiative study showed that estrogen reduced fractures and actually prevented heart attacks in the 50 to 60-year-old age group. And then the 2021 International Journal of Molecular Sciences. So management of osteoporosis in men. I wanted to include men in this presentation too. Hypogonadal patients, so that it's men with testosterone deficiency, may be treated with testosterone replacement therapy. 2022 Archives Endocrinology Metabolism, male osteoporosis in men with symptomatic hypogonadism, testosterone replacement, if indicated, can improve bone mineral density. And then 2021 Journal of Clinical Medicine, testosterone and bone health in men. Testosterone replacement therapy should be considered as one of the treatment options to improve hypogonadal symptoms and bone mineral density simultaneously in symptomatic hypogonadal men with osteopenia. Okay, so how do hormones improve bone density? First, we'll talk about the osteoblasts and the osteoclasts. So the osteoblasts are the cells that build new bone. They are responsible for bone formation and remodeling. They're important for healing damaged or broken bone. So I like to call them the builders. The osteoclasts are the cells that dissolve and break down bone tissue. They're responsible for reabsorption of old damaged bone. So I like to call them the demo guys. The osteocytes are the cells that coordinate the activity of the osteoblast and osteoclast. So they're the contractors. So estrogen works on the osteoclasts by inhibiting osteoclast activity, preventing excessive bone resorption. They promote osteoclast apoptosis, which means programmed cell death. So it limits the lifespan of the osteoclasts. So it controls the number of active osteoclasts in the bone tissue. Progesterone promotes osteoblast activity, stimulating bone formation, and also stimulates the differentiation of osteoblasts into mature osteoblasts. And then testosterone promotes osteoblast activity, stimulating bone formation. So all of the hormones play a role. Estrogen is definitely the hardest working one. And then I wanted to talk about the DEXA scan. So the DEXA scan is our way of measuring bone mineral density. It's not our only way of measuring bone quality, but it's the most commonly used. And the DEXA scan gives us a T-score, which is a number that compares your bone density to that of a healthy 30-year-old. A T-score between -1 or greater is considered normal. Between -1 to -2.5 is osteopenia, and between -2.5 or less is considered osteoporosis. So I wanted to share some mini case studies, and I call them mini because the information that I can give you is limited. I was asked by Nico and Jason to give this presentation when I was in between practices. I had left my previous practice and I was preparing to start my new practice. So I wasn't able to actually meet with these women to discuss, what they were eating, how they were exercising, what supplements they were taking. So I wasn't able to get that type of information from them. But I did have access to bone density, DEXA scans, and I had access to their medication, so I could see that they were taking bioidentical hormones and not any of the osteoporosis drugs or the medications for osteoporosis. And so what I wanted to show you in this case, this is a 72-year-old woman. She's been on bioidentical hormones since 2017. And so in 2015, you see her T-scores. So in the spine, -3.4, -2.8 in the total hip, -2.8 in the femoral neck, and then -3.6 in the forearm. And, this first DEXA scan was probably when she was around 65, because that's when most people are being recommended DEXA scan. That's when most insurance companies are recommending the DEXA scan. But you see, waiting till someone's 65 for their first DEXA scan, and she was already in significant osteoporosis by then. So ideally, we want women to be getting their bone densities in their 50s, closer to the onset of their menopause. But she already had significant osteoporosis by the time she had her first DEXA scan. And so she started hormones in 2017. And then by 2018, you see the improvement to -3.1 in the spine. And then in 2020 to -2.6, and then in 2022 to -2.4. So from osteoporosis to osteopenia by 2022. And then in the hip from -2.8 to -2.6, -2.5, and then -2.4. So now here as well, osteopenia. And then from negative 2.8, stayed at negative 2.8. She had a decrease here. I don't know why that happened, but a decline in her bone density here, but then an improvement again in 2022 to negative 2.3. So you see all of these went from osteoporosis to osteopenia. And then in the forearm, negative 3.6, negative 3.2, negative 2.9, and then in 2022, negative 2.7. So still osteoporosis in the forearm, but all of these have significantly improved. And it says here, no significant bone loss was observed. Another case, this is a 76-year-old woman. She started hormones in 2019. So 72-ish when she started hormone therapy. And in 2015, let's see, she had osteoporosis here in 2015. It got worse in 2018. She started the hormones in 2019. Oh, here. So she's worse in 2019 here. And that's when she started the hormones. And then it improved in 2021. And then again, you see here, she was getting worse, getting worse, getting worse, started the hormones. And then you see the improvement here in 2021. And then as well in the femoral neck, all of these are getting worse, but improved after starting hormone therapy. And then this in her forearm, she isn't improving in her forearm. She is still having some bone loss. But the change from negative 4.3 to negative 4.5 is not considered significant. It's a small change. And so they're saying no significant bone loss was observed here, but definitely some improvement in the other areas. And then this is a 69-year-old woman. She's on hormone therapy. I can't see the top of the slide here. Let's see, how can I get that? All right, I can't see the top of the slide because of the screen sharing. Okay, so negative 0.6, positive 0.2, 0.3, 0.3. Okay, so you see the improvement from negative 1.2 to negative 0.8. This declined, but this came back up again. And then from negative 1.3, got worse in 2019, but improved in 2021 and improved further in 2023. And then only one previous study in the forum here in negative 1.5, improved to negative 1.2, and improved to negative 1.0. A 58-year-old female on hormones since 2021. So she started younger. She started 56 when she started the hormone therapy, but her first DEXA at age 55 in 2020, she already had osteoporosis. So checking your first DEXA at a younger age is definitely worthwhile, even if the insurance doesn't cover it, because you see she already has osteoporosis. And so then she started the hormones following this report and improved to negative 2.7, improved from negative 2.2 to negative 1.7, and then from negative 2.7 to negative 2.6. And this is an 80-year-old woman. She's been on BHRT since 2016. I don't have reports of her previous DEXA scans, but you see even after age 77, she's still improving. This is a slight decrease here, very slight decrease. This is a slight increase, and this is an increase in bone density. But you see no significant bone loss was observed. So she's still improving her bone density even at age 80. A 71-year-old woman since on BHRT since 2016, from negative 0.1 to positive 0.2, negative 1.6 to negative 1.2. So you see these are improved. This is a slight decrease here in bone density, but you see no significant bone loss was observed because this is a very slight decrease. Okay, so the efficacy of bioidentical hormones, there are several factors. So, your baseline bone density is going to make a difference. So, if we're able to start hormones before the bone density has had a chance to decline too far, bioidentical hormones are going to be more effective. Also, someone's overall health. So, if a person has a lot of inflammation, or if they're not eating a healthy diet, or if they're not physically active, that will also impact the how effective the bioidentical hormones are. And age, Earlier is better. So starting the bioidentical hormone therapy closer to the onset of menopause before developing osteopenia and osteoporosis is going to make them more effective, and longer duration is better. So, in summary, in addition to diet, nutrition, and lifestyle modifications, bioidentical hormone therapy is a safe and effective way to treat osteopenia and to prevent osteopenia and osteoporosis. It's important to discuss your individual risks with your healthcare provider. Thank you, everyone, for participating in the webinar today. I'll go ahead and answer questions from the chat. Okay, the first question from Karen. The first question I was asked with a breast cancer diagnosis 4 years ago was, did I use hormone replacement? Definitely left the impression of the correlation. Okay, so Karen, remember what I said in the presentation. Unfortunately, some doctors aren't keeping up with the latest research, and I showed you the study that showed that estrogen replacement actually decreases the risk of breast cancer. There is a slightly small increased risk of breast cancer when Provera was added to Premarin. So medroxyprogesterone acetate or Provera is synthetic progesterone. There's a slightly increased risk when that's used in hormone replacement therapy. Next question, is there any data regarding family history of breast cancer and taking BHRT? So we do know that if there's a family history of BRCA gene positive breast cancer, there's an increased risk of breast cancer. But if the BRCA gene is negative, there's no increased risk. What is the cutoff age for taking BHRT if the person doesn't have osteoporosis? So there is no cutoff age, but like I said, there's more benefit if you start BHRT earlier, but there isn't a cutoff age. Okay, Jen says the BRCA gene was negative in the sibling with breast cancer. So if there's no BRCA gene positivity, then there is no increased risk for breast cancer. If I am on hormone suppressant like letrozole, wouldn't this be contraindicated? So yes, letrozole is an estrogen blocker. So if your oncologist is prescribing letrozole, he or she wants your estrogen levels to be lower. So you would not want to be taking hormone replacement therapy at this time. Is there a dosage level of BHRT that is too much and could cause side effects? And that's the benefit of BHRT, is that we can monitor the levels in your blood so we can make sure you're not getting too much. But if you're not monitoring levels, and the side effects could be, if your levels are too high, too much estrogen can cause breast discomfort. It might also cause spotting in a woman who still has a uterus, but that's easily reversible by reducing the estrogen levels. And then if progesterone is too high, progesterone has a nice calming, relaxing effect. It can even help you sleep. So if your progesterone level is too high, that can make you sleepy during the day, and that can be resolved by lowering your progesterone levels. If testosterone levels are too high, you might have acne or facial hair. You can reduce that by lowering your testosterone levels. Next question, what levels of hormones in blood are ideal? So part of that also has to do with each person individually, because everyone has different needs. And so someone might feel better on a lower dose of hormones and someone might need more. But ideally, levels for estradiol, I like to see levels between 40 and 80. I like to see progesterone in the luteal range and testosterone in the middle to upper range. Can you take BHRT if you have fibroids? So fibroids are actually caused by a hormonal imbalance. Typically, it's an estrogen dominant state, and so progesterone can actually help shrink fibroids, especially if the fibroids haven't gotten too large yet. My functional doctor put me on raloxifene. I have SIBO. Your opinion? I don't really understand your question, Shahira. So raloxifene is for osteoporosis, and it can also be used for breast cancer prevention. SIBO is small intestinal bacterial overgrowth. So I don't understand your question regarding the two. Next question. I have Hashimoto's thyroiditis, hypothyroid. My last period was 10 to 12 years ago. I am 59 and have osteopenia. I broke both wrists 5 years ago. Is it too late to start BHRT? No, it's not too late. You can still start BHRT. Can someone start taking BHRT for the first time in her 70s? Yes, absolutely. She can start in her 70s, but again, you'll reap more benefits if you start it earlier. Not a question, but thank you for sharing the slides on the improvements of the DEXA scans of the women that took BHRT. You're welcome. Next question. My doctor just suggested I start taking alendronate sodium to increase bone density. I don't have my bone density numbers. I'm concerned with all the side effects, so I haven't started taking it. How is this different from BHRT? I understand your concerns regarding the side effects for alendronate. So alendronate is a bisphosphonate, and what it does is it inhibits osteoclast activity. So it inhibits the resorption of old damaged bones. So what happens is you get a buildup of those old damaged bone tissue, which results in hard, brittle bone, not strong bone. With BHRT, you get better quality bone. Next question. I am 72 and have osteoporosis. Is it too late to start BHRT? No, it's not too late, but more benefits are seen if you start BHRT younger. What is the ingredient in soda that is harmful for bone strength? And that's phosphoric acid. Is BHRT covered by insurance? No, it's not covered by insurance. That's a good question. But it costs about $40 to $45 a month generally. Could I be on BHRT and raloxifene? So I don't know, Shahir, of any studies using BHRT and raloxifene together, so I can't answer to that. I'm sorry. Next question. My 95-year-old mom is going on the osteoporosis prescription. I can't change that. Which of the prescriptions is the least of the evils? So I don't love the bisphosphonates because they result in hard, brittle bone. So other options would be Prolia, that can help build bone, and Timolose can also help build bone. Is it riskier for someone more than 10 years post-menopause to start BHRT? So it's not about the age. It's not the age that you're starting BHRT, but it's the quality of your health. So after 10 years post-menopause, if you've developed heart disease or high blood pressure or high cholesterol, or if you're overweight or obese, so it's your health status when you start BHRT that would increase your risk. But if you're healthy 10 years post-menopause, it doesn't increase your risks. Is it not recommended for a breast cancer survivor to take BHRT? No, a breast cancer survivor can safely take BHRT, and many breast cancer survivors do. What are the side effects of BHRT? Where do I go to get started on? And are you taking new patients? So yes, I am taking new patients. Side effects, like I mentioned, would be just based on not monitoring the levels if your levels are too high. So breast tenderness, spotting, feeling tired if your progesterone is high, acne, facial hair if your testosterone is too high. But all of those are reversible by adjusting the doses. Is the harmful ingredient in soda also found in other fizzy drinks? So, what makes drinks fizzy is the carbonation. It's not the carbonation that causes bone loss, it's the phosphoric acid. And I believe the dark sodas are more highly associated with bone loss. If BHRT is not covered by insurance, how do I get started on them? So not all doctors prescribe bioidentical hormones, so you would need to see a functional medicine doctor to prescribe them for you. And then the compounding pharmacies make the bioidentical hormones. What do you think about pellet therapy for BHRT? I have been on that for 14 years, but tried BHRT gels for a year and all my levels crashed. So, for those that don't know, pellet therapy are hormone that come in pellets about the size of a small grain of rice. And these pellets are inserted into your bottom. They make estrogen and testosterone pellets. They don't make progesterone pellets, so you have to take progesterone separately. But what I don't like about pellet therapy is that these pellets are inserted every 3 to 4 months or maybe 5 months, depending on how quickly you metabolize them. And when they're inserted, your hormone levels get very high in the blood, and then they wear off and they drop over several months. And then you get your next pellets and they rise again and they wear off over 3 to 4 months. And so you get these sharp rises and falls in your hormone levels that aren't physiologic. We don't make hormones every 3 to 4 months. We make hormones every day, and our levels are more consistent. So when we use creams and apply them daily, we keep our levels of our hormones more steady. Um, and oftentimes, when the levels get so high with those pellets, you can't easily adjust them. You have to just wait for those pellets to wear off after 3 or 4 months. And so if you're experiencing side effects like hair loss or your skin's breaking out, there's nothing you can do to lower your dose. You just have to wait for those pellets to wear off every 3 or 4 months. And then when you switch to the gels, you probably experience a sharp drop from those very high levels to more normal levels. And so what you have to do is transition so that you gradually decrease and so you probably experienced just a very sudden and sharp drop in your levels. Next question, where is the best place to get a DEXA scan if my insurance won't pay for it? So you're just going to want to compare the prices at any of the local imaging facilities like Scottsdale Medical Imaging or Smile or Simon Med, any of the imaging facilities. You're just going to check the prices. Do you recommend calcium supplements for building bone? Does the calcium affect the cardiovascular system? So yes, I do recommend calcium, but I prefer in the form of food from your diet. So calcium from dark green leafy vegetables, dairy if you eat dairy, sardines if you eat sardines. But if you don't eat those, then if you're not getting enough calcium from your food, then I do recommend supplements. And to keep calcium out of your cardiovascular system, you're going to want to take vitamin K2. So vitamin D3 helps you absorb the calcium. Vitamin K2 helps keep the calcium out of your coronary arteries and other tissues and into the bone. Do you suggest taking either synthetic or natural hormones? I recommend taking natural hormones. I never recommend taking synthetic hormones. Can we get a copy of your presentation? So yes, it's being recorded. If the breast cancer was estrogen receptor positive, can BHRT be taken? It can. You're just going to need to monitor closely. I'm taking the lowest amount of bioidentical hormone and experiencing quite a bit of breast discomfort. Any thoughts? I'm using a TRIT for estrogen and testosterone. I don't know what a TRIT is. I don't know what you mean by TRIT. And a cream for progesterone. So if you're experiencing breast discomfort, that means that your hormones aren't balanced properly and you need to have an adjustment. You probably need either more progesterone or less estrogen. Is the estradiol patch considered bioidentical? The estradiol patch is bioidentical, and the only problem with it is that you can't customize the dose with the patch. You're limited to the doses that the patch is available in. And the other problem is that some people are sensitive to the adhesive. They can get some skin irritation from the adhesive from the patch. Can you measure progesterone level in blood? If so, what is ideal? Um, there isn't a great way to measure progesterone, either blood, saliva, or urine, but you can measure it. And I prefer to see progesterone in the luteal range. What do you think about zoledronic acid injections? So zoledronic acid is a bisphosphonate. So again, that inhibits osteoclast activity. So you get a buildup of old damaged bone, and so the bone becomes hard and brittle, not strong. Which breast cancer is the best for BHRT? Receptor positive? Receptor negative is better. Next question. My gyno prescribed estradiol vaginal cream 1 gram 2 times a week. Would that have any positive effect on bone density? So no, vaginal estrogen creams will only have will only have a local effect in the vagina. It doesn't become systemic, so it won't help with bone density. What do you think of supplements, calcium, D3, K2, and magnesium for bone health? Are they necessary? Still take these along with BHRT? Yes, so you still need to take the vitamins and supplements even along with BHRT for bone health. And then the next question. Should you have hormone levels be checked before going to BHRT? Yes, I always recommend checking a baseline hormone level before starting BHRT and then monitoring them periodically while you're taking hormones to make adjustments as needed. Does estradiol patch help bone density? Yes, it does. It does help improve bone density, and it is bioidentical. It's just not customizable. And that was the last question.